All right, so this is the second video that I'm making. That's kind of a miniature lecture series looking at some of the most common and important topics within MDAA 202. We're looking on this one at specific coding. Now, to start off, what you see listed here is some of the common CPT modifiers. What I'm going to start off by talking about at first, though, is the ICD and the idea of CPT. So, what we know of as the ICD is it is the International Classification of Diseases. We're currently in our 10th version. I believe the 11th version actually comes out the start of next year. I might be wrong about that, but with each ICD revision, we can have, we tend to see more codes added to get more specific. And ICDs are also important because it's how we can track prevalence of conditions, and we can make public health decisions based on the ICD rates that we see, especially if that information is collected. In fact, the real origination of the ICD, part of that was to examine mortality rates. Now, the ICD isn't really a major concern for this course. The ICD is a lot more straightforward than the CPT. And in fact, the ICD is pretty much just as simple as I have this condition, I search through the ICD manual, and boom, I use that exact code. There's nothing more to it. Now, CPT, on the other hand, is the current procedural technology code set. It's literally created by the American Medical Association. Nowadays, the Centers for Medicare and Medicaid Services, the CMS, helps update it and set these standards for the rules. There's levels or categories of CPT codes, 1 through 3. And category 1 codes, we look at, they tend to be the most numerous. These are the standard 5-digit codes without decimals. Category 2 codes are used to track performance measures. They're not reimbursable, so we can use these codes for statistics. So if we're looking at a practice that wants to that does tobacco use cessation counseling, you know, we can use these codes for that. And then category 3 codes, they're like experimental. These codes tend to be temporary and often are seen for new technologies, procedures, etc. They're going to have both numbers and alphabets in them. It's not all that uncommon to see a category 3 code become a category 1 code in a later iteration of the CPT. And speaking of that, we actually often see regular updates. Almost, I believe they try to update yearly the CPT. Now, for the purpose of this course, we're really only caring about category 1 codes right now. With category 1 codes, these are divided up into further categories. So the first type, and one of the most common and important types that exist, are evaluation and management, or EM codes. These are literally what you think of as your standard office visit. The definition of this type of code is literally the physician service that is done to determine the best course of patient care. Okay, so if you have a problem, you go see your doctor about it. They perform an exam, and they use information that they collect as part of the patient history and the exam to determine best course of patient care. Anesthesia codes, obviously, are applicable only to anesthesia. Surgery codes are for surgical procedures. Radiology are radiology services. Pathology and laboratory, these are typically applying only to tests that have to occur in a lab. So you're talking about, you take someone's blood and are running a test. You're looking for an infection. You're looking for evidence of, blood clotting, things of that nature. And then general medicine codes are essentially the therapeutic or diagnostic procedures utilizing medicine. An important part of the CPT, though, is modifiers. And modifiers are going to be the 2-digit codes that we see listed after. And we'll talk more about these here shortly, and they're obviously one of the most important parts of the course because we want to logically look at modifiers and how to use them. But really, they're there to provide more information related to a code. Okay, they essentially kind of have two purposes. They can alter the billing. So if we use modifier 50, for instance, the standard for that is the for the bilateral procedures that modifier 50 indicates, the standard is that you get reimbursed 100% for procedure 1, and procedure 2 is 50% reimbursement. We can see something else like modifier 26. Modifier 26 is not explained very well on this chart, but we're essentially using that to show like a repeat procedure, for instance. Okay. Now, moving on to talk about E/M codes. These are incredibly common, as I said. In fact, our standard outpatient services are going to be codes that range from 99201 to 99215. And the 201 to 205 range is outpatient services for a new patient. Okay? And each number increases the difficulty of the evaluation and management visit. For established patients, it's 211 through 215, and the same thing applies. A level 1 is the 11, a level 5 is the 215. We also have basic codes used for hospital, and they're broken down to look at if you're admitted to the hospital for observation, or it could be if you're admitted for inpatient care. We also have codes for consultations, and it's important to realize that a consultation in healthcare is not a referral. A referral is going to happen when you need to see a different specialty, okay? Like you go to your primary care, and they tell you that this condition should be managed by a pulmonologist, for instance. That's a referral. You're going to go see a new doctor who's going to fully take over your care. A consultation is different. Typically, we see consultations when you've got almost subspecialties within a specialty. So in cardiology, we can kind of look at as having multiple subspecialties. And you have the regular cardiologist, and then you can have a certain type of cardiologist that's called a electrophysiologist. And it's not all that uncommon for the cardiologist to have the electrophysiologist perform a consult. And that can include that doctor coming to do a certain test, to evaluate test results, things like that. You're not actually seeing that consulting doctor, though, to handle your care. That doctor is just simply giving input to the primary treating physician in this case, okay? There's a big difference, and in fact, Medicare does not reimburse consultations anymore because there is an abuse of consult codes previously. But then there's also some other categories of EM. You know, you can talk about nursing homes, critical care services, emergency departments, and then like home care. Like if you have a medical professional, like a nurse, come out to the home to do certain things. Now, getting back to our modifiers. As I said before, these really are used to provide more information about a code. And as you'll see on this chart here from 5.2 in our text, or table 5.2, it's from page 148, and it's actually section 5.4. You'll see that certain modifiers can only be used for certain types of codes. All right. Obviously, any modifier related to anesthesia is only usable for anesthesia. Codes like 24 and 25, which are only related to EM services, can only be used for EM. All right. And then there's code 62 or code 66, and that 62 is two surgeons and 66 is a surgical team. You would never code either of those for EM, for anesthesia, or for pathology, because a surgical team's not doing laboratory research. A surgical team isn't needed for anesthesia, and a surgical team has nothing to do with EM care, right? So it's important to consider why a code is being used to see if it's appropriately being used. And this is one of the first steps for that, is to make sure that that code is actually compatible with the service type. Now, a few things to note. The specific modifiers that we looked at for this last week. So the first one is modifier 58. 58 is strictly what's called a staged or related procedure by the same physician during the post-operative period. All right. Now, related procedures are self-explanatory. Staged is just another way to say that it was planned to be done at the same time. Okay, so if you've had a tumor in your abdomen and you just so happen to, for instance, need some sort of plastic surgery done after that tumor is removed, these things are going to be directly related, okay? This plastic surgery had to be performed because of the surgery for the tumor, okay? It's also important to remember that this code can be used if another procedure is planned for later due to the surgery. It can also be used if the new procedure was more extensive than the original procedure, or if the procedure is done as part of the therapy or recovery after the procedure. Next, we're going to get into two very similar codes here. 79 is the unrelated procedure or service by the same physician during the post-operative period. This can only be used when an unrelated surgical procedure is performed by the same physician. All right, very straightforward. Two completely unrelated surgical procedures. Let's say you see your orthopedic and you get a surgery on your ankle, and a week later, you're on your crutches outside and it's raining and you slip, fall, and you break your arm. And you have to get pins put in it, and your orthopedic puts the pins in your arm, resets your arm. That would be an unrelated procedure or service. Because, and I haven't mentioned it yet, but really if you look through, especially with surgery, we're talking about the same physician always, or the same practice, because sometimes medical practices where there's multiple physicians of the same specialty, they can share patients. Sometimes we can see non-operative sports medicine doctors, for instance, handling the initial EM and handling the post-operative management, whereas their medical practice partner only does the surgery, right? And there's actually codes for that. 54 is for surgical care only, okay? And 55 is post-operative management, and 56 is pre-operative management. So we can see some more rare codes being thrown around. It's also important to consider the code that I mentioned earlier, 66, for a surgical team. This is going to involve very complex surgeries, and it's going to involve specialists of different specialties. The most common time that we see this done is for transplants, sometimes with extreme traumas where there's multiple operations that need to be done. Sometimes you'll see a surgical team used for that to quickly get them done, especially if the time is of the essence to fix multiple problems. Well, definitely you can see it used for that. And then 62 for two surgeons. Again, you can it's uncommon, but not as uncommon as a surgical team. You can see surgeries requiring two specialists of different types of surgery. So back to the modifiers we're actually discussing. Again, 79 is unrelated procedure, same physician, generally in the post-operative period. Now, a very, very similar code is 59. This is a distinct procedural service. So we're, again, talking about an unrelated procedure. But this time it has to be on the same day, and it has to be a completely different patient encounter. Okay? Oftentimes for this, we see a different body site, so different anatomy. You'll see a different incision, a different type of injury, and '59 really means that a procedure is performed that is outside of the surgical package already being done. So the example I like to use for this is when you come into your dermatologist and you have on your left shoulder, you've got some skin lesions that are going to be removed. And as part of the dermatologist's, physical exam for you that day, they notice on your abdomen a different type of lesion, mole, whatever, and they decide that they're going to biopsy it because it's different, right? That biopsy code would utilize 59, okay? Because again, this is an unrelated procedure. That biopsy is completely unrelated to the other removals, because it as part of the global package, a excision of a skin lesion typically will include the biopsy of said lesion. Okay, now it's possible to perform the biopsy and then come back in a week or whatever and then do the removal. All right, that would be a completely different scenario. That would be coded under 58 as the modifier, because remember, the biopsy is a less it's the concept that we might have to perform an excision later on is part of understanding of a biopsy. You do the biopsy, you might have to remove whatever was biopsied, right? So that would be 58 because they're directly related, and realistically, it's something that's in the possible patient plan of, if this biopsy comes back as indicating a malignant growth, we will be excising it, okay? Now, moving on to the EM modifiers. An important part of EM is to also recognize that the evaluation is going to include a patient history of some form. And we kind of have 4 different levels of evaluation. The first one we look at is called problem focused, where literally the patient would come in and tell you their problem, or what we would call the chief complaint, or CC, and you literally just ask them only about their present condition. We call it the history of present illness. The next type gets a little more detailed. It's called expanded problem focused. So we again inquire about the chief complaint. You get a brief history of their present illness. And then we do what's called a review of systems. Now, for this review of systems, a full review of systems, you would go through every body system and ask a couple questions related to it. You would start with what we call constitutional symptoms, which are things that we would measure, typically, parts of vitals, weight, etc. But we also would ask, do you have change in vision? Have you had changes in smell? Do you have any issues with your heart? Any dizziness? Is your breathing fine? Etc. Is your bowel and bladder functioning normally? Has any of that changed? With your body, have you experienced any muscular weakness? The integument, has your skin changed in any way? Do you have new growths, etc.? And the list keeps going on and on. The expanded problem-focused history is only going to focus on the specific body system directly related to the chief complaint. Next, we move on to what's called detailed. So again, further adding on, and we're also going to, while still only looking at the pertinent history system and potentially any related systems, you're going to take a pertinent look at past medical history and social history. And when we talk about social history, we're really looking at everything not covered under the patient's medical history, not covered under their family history. You know, this is where the doctor asks about alcohol, drug use, you know, what your diet's like, how much you sleep, etc. Comprehensive physical examinations are the last. This is as deep as you can go. You get the chief complaint, you take an extended history of the present illness, you complete the review of systems. So that's literally, you're going to go through every single body system that exists of any type. You're going to get a full past medical history from the day they were born, as much as they can remember. You're going to get information for family, and that's going to be siblings, parents, and hopefully grandparents. And you're going to collect full social history. So now you're definitely asking alcohol use, drug use. You're going to look at smoking, how much water somebody drinks. Are they on the diet? You're asking about any dietary supplements, anything that you can possibly think of. You know, what your hobbies are. Does your chief complaint interfere with your hobbies? You're going to ask about their job. Does their chief complaint interfere with their job? If you don't know what their job is, you're going to ask, you know, what do you do on a daily basis at your job? Okay? All of that is incredibly important when evaluating and doing a comprehensive exam. So a part of that exam, though, can also determine the EM code level. So remember how I said before, the CPT for outpatient visits, for instance, and that's what I'm going to focus on here, kind of has different levels to it. So, for instance, level 3, so if we're seeing a new patient with a level 3 problem, that would be coded as 99203. And what we're doing with that is we're taking a detailed history, we're taking a detailed examination, and the medical decision tends to be low-ish complexity. Okay? Now, a level 5, we're doing a comprehensive history. We're doing a comprehensive exam. The medical decision-making tends to be of high complexity. You're going to be involving multiple body systems to determine what's going on, right? We tend to see this used in individuals that have chronic disorders that overlap with each other. And there are guidelines that exist for how to use that. Now, moving on to the EM modifiers, the two big ones are 24 and 25. So with 24, and again, both of these can only be used with EM, with evaluation and management. So 24 is a completely unrelated evaluation and management service by the same physician during the post-operative period. So if you go to your orthopedic and last week you had a surgery on your knee, and let's say you slipped and fell on your crutches again, but this time instead of breaking your arm, you just landed really hard on your back, and now your back hurts. You go and see your ortho, and they do a evaluation of your condition. This is 24. You're in your post-operative period. The reason you're seeing them is completely unrelated. Next, let's say for 25, this is a significant but separately identifiable EM service. All right. And this one's it's going to be a little different. What we see for this code, though, is looking at, again, a separate and identifiable condition. All right. One way that we can look at this, right, is if you come into your primary care for your annual, work required physical exam or your insurance required physical exam. You were talking to your doctor about, if your health status has changed in the previous year. And you start to mention a couple things, and lo and behold, the few things you mention directly relate to some sort of new illness. So, because of that new illness, your physician will now essentially redo an exam focused on that illness. Because ideally, every condition we have gets its own evaluation specific to that condition. Okay? So for every chief complaint that a patient has, we should be seeing a separate EM. So that's what 25 is for. We're looking at a different EM for a different problem. You could come in, your physical exam, let's just say you're not a new patient, and we're billing for your standard physical exam. We're talking like a 99213 or so. We're a little bit of the details, but suddenly you say, oh yeah, I've got this, this, and this. And the doctor has to say, all right, let's take a step back. We're now going to do a comprehensive exam for that. And then we see a 99214, for instance, because let's say it's a potentially multi-system condition where multiple things need checked out. It could be a cardiovascular problem, or it could be respiratory. We need to check both systems, okay? And that's what we're using 25 for. It's a completely separate EM service that gets provided.